Good afternoon, everyone. Welcome for today's series, nutrition series. My name is Alexander Bogo, one of the team in this webinar organization. Our topic today will be discussing or looking into the issues related to disease-related malnutrition. Our speaker today is none other than Agri Mokua, a nutritionist, clinical nutritionist from Kenyatta National Hospital, who has a wealth of experience in terms of management of critical care patients. And maybe for information, last week we had a Malnutrition Awareness Week that was being conducted by American Association for Parenteral Nutrition. And we have always realized that during management of patient in clinical setup has some unique challenges compared to managing patients who have malnutrition, so to speak, undernutrition because of starvation or lack of food. Actually, there is what we call secondary malnutrition. And management of secondary malnutrition is a little bit complicated. We don't have protocols that provide guidelines in terms of managing these patients. Neither do we have a clear or good data that can be able to show the current burden. So these are the issues that we are going to have a look into. Then we discuss and see the way forward in respect to improving the quality of nutrition care for our patients in clinical setting. Therefore, I wish to welcome Mr. Agri Mokua so that he can take us through this interesting topic. So welcome, listen, post any question you have. We shall address them towards the end of the session.
Well, thank you very much, Alexander, for the introduction. And I think it is prudent for us to discuss this, considering we were celebrating Malnutrition Awareness Week just the other day. So it would be prudent for us to understand in terms of what are we discussing today, because more often than not, you'll find like when you talk about malnutrition, majority of the people tend to go towards the aspect of starvation as a result of starvation. But when it comes to disease-related malnutrition, you find like the dynamics are a bit different. So it would be worthy of us to have this discussion today, so that now we can try to see in terms of what are the circumstances behind, or how different are they when you talk about disease-related malnutrition vis-a-vis when you're just simply talking about malnutrition. So without further ado, perhaps you can have a look at what malnutrition is all about, of which it is in reference to either deficiencies or excess in nutrient intake, the imbalance of the essential nutrients, or the impaired nutrient utilization. So as you can see there are three aspects there. There is the intake bit, there is the aspect of now the imbalance, and then there's the aspect of now impairment in terms of those nutrient utilization, because you can find someone, the intake is not the problem, but now the aspect of now utilization, nutrient utilization is where there's a challenge. And if we can go further in terms of that definition, you are actually concentrating more at the cellular level, the imbalance that is created at the cellular level in terms of the supply of those nutrients and the energy itself, and trying to look at now what are the body requirements in terms of its demands for them, so that it can be able to ensure normal maintenance and growth, risk maintaining the bodily functions. So as you can see from that definition, so you'll find like malnutrition doesn't just result as a result of just in a deficiencies in the intake aspect, So we also have to consider the other aspects in terms of the digestion aspect, the utilization of those nutrients perspectives. So when you go now into the etiology of it, you see it has those three broad categories, whereby it can be either starvation related, of which I believe that's what you'll find mostly in the programmatic aspect, whereby they try to use the F100, F75 together with the RUTF. But now when it comes now to the clinical setup, you see you have to think differently, because now when it comes to the clinical setup, more often than not, you're dealing with either chronic disease related or acute disease or injury related. So you usually get malnutrition together with stress-related catabolism, either as a result of inflammation, increases the risk of infections, organ dysfunction, and impaired healing. Therefore, understanding individual patient situations in the context of different inflammatory processes will greatly help more clearly define the varying effects and the rate at which malnutrition may develop in your patients. So if you're to look at now the metabolic processes, that's where you'll get, there's decreased insulin levels, increased catecholamine secretions, you have increased glycogen lysis, lipolysis, and protein catabolism. And also you are likely to get reduced glucose oxidation and ketogenesis, resulting either in elevated triglyceride levels from the oxidized free fatty acids. So when you look at now in the aspect of inflammation, you get like inflammation make the metabolic processes worse due to the pro-inflammatory cytokine storm. That is the tumor necrotizing factor alpha, interleukin 1, beta, and interleukin 6, which you get like the resultant effect is increased resting energy expenditure or metabolism. You can also get sodium and fluid retention, which would be characterized by either hypoalbuminemia in your patient. At times, you'll also likely to get insulin resistance that is going to be characterized by hyperglycemia in your patient with reduced protein synthesis. Now, because determining the presence and the degree of inflammation is not always straightforward, you'll find like at times you'll greatly utilize some of the signs to tell you there's inflammation, of which in acute inflammation, the signs and symptoms would perhaps include swelling, aspects of hypothermia or fever. There could be aspects of pain or change in the discoloration of the skin, perhaps. And then there could be marked increase in the C-reactive protein when you're doing now your biochemical parameters. They'll tend to be elevated together with a picture of leukocytosis in your patient. But however, when you're moving now towards the chronic disease aspects, you'll find like the conditions may even those particular conditions may even lack. That is now like the classical signs, which are usually seen in the acute inflammatory phase. In the acute inflammatory phase, at times they might lack. So our focus should be on the identification of the potential underlying causes of malnutrition, as well as of individual preferences, the resources, the expectations, evaluation of the severity of the nutritional deficit, and a critical review of the existing dietary prescriptions that are available to the patient for use. And at times you get like a protein breakdown so that you can be able to synthesize acute protein phase, which are usually the albumin, fibrinogen, and transferrin, might end up even resulting in a protein loss in an individual equivalent to 1 kilogram of muscle tissue in such kind of a patient. So most important thing is to identify and eliminate those potential causes is very, very fundamental. So when we are talking about disease-related malnutrition, you'll get like the disease-related factors which might lead to malnutrition, as you can see there from the list. You can have either insufficient nutrient intake or food intake. And this could be either as a result of nil per oral orders from the doctor, either the patient is scheduled for ill for a surgery, or perhaps there is poor appetite in your patient, or their taste changes, or perhaps there are other symptoms like nausea, vomiting, or even treatment-induced side effects, coupled with sometimes patients will come in with dysphagia, that is difficulty in swallowing. Or even at times, they might even come in unconscious, as in the case of those who are admitted in the critical care units. Secondly, when you're talking now in terms of now the impaired nutrient digestion and absorption, you'd mostly see this one, especially in the GI diseases, that is the gastrointestinal diseases, such as short bowel syndrome, etc. And at times you get, there is also increased requirements for nutrients, as in the cases of trauma, endocrine diseases, and sepsis. So you get like, those can also be able to result in malnutrition in our patients. And to a greater extent, you get also, there's the aspect of increased nutrient losses. Especially when you're having wounds, when you're talking about issues to do with the stomas and everything, because depending with the site of the stoma, then it impairs in terms of how much is absorbed into the body system of that particular patient. So how you deal with such kind of patients would be perhaps very different from how you perhaps deal with starvation-related malnutrition. So you see there, you need to be very, very specific in terms of what are the losses that this patient is encountering, to what degree are those losses, so that now, even when you're doing drafting now your therapy in your patient, for it to work, you see, you have to make those into consideration. So you won't end up using the programmatic way of managing that patient simply because they have malnutrition, but you have to think in depth in terms of how do we sort out this problem. Because protein losing enteropathy is mostly is usually characterized by severe loss of up to 60% of the total albumin pool of the serum proteins, of which you understand the serum proteins usually reflects the balance between the protein synthesis, the metabolism, and the loss also. So take into consideration now the aspects of the intestine, the gut of that particular individual. So it is very, very important for us to also look into that. So as a result of the abnormalities of the lymphatic flow, that's where you get now, you end up with the protein losing enteropathies for your patients. Now, going now into terms of now, how does malnutrition affect the body systems that we're looking into? So you get like depletion of the fat and muscle together with organ mass has an effect in all the body systems. If you have to look at now the respiratory system, you get weakened respiratory muscles with which you'll end up perhaps with having a weak cough reflex. And as a result, you're going to highly likely be getting increased risk of chest infections. Okay. When you look at now the musculoskeletal systems, since it's going to result mostly into the loss of bone mass with increased risk of getting fractures in your patient. There's also increased fatigue with slackening of the voluntary movement, whereby if you're to talk to the patient, is like adamant. He doesn't really want to get out of bed to move around. Perhaps you to look now in terms of the picture when it comes to the endocrine system, there's also the suppression of the thyroid hormone, that is the T3 and the T4, the gonadotropins, the testosterone, estrogen, and progesterone, together also with the insulin, when you're trying to evaluate now the endocrine system. If you come to the GI system, you're going to get changes in the pancreatic exocrine function. Also in terms of intestinal blood flow, the villus architecture, because they become atrophied. There's also aspects to do with the intestinal permeability that is going to be characterized by either malabsorption or diarrhea in your patients. Under the genitourinary system, there's reduced renal perfusion and also reduced glomerular filtration rate. So you get there's a decreased capacity to excrete the acid load in your patient. So thereby you're getting now excess salt or sodium and water load, which perhaps would be characterized by edema in your patient as a result of the effect of malnutrition. So at the end of it all, you get there's also impaired thermoregulation, because you remember fluid becomes very, very important when it comes to thermoregulation. Other aspects might even be brought about depression, irritability, and also a wide spectrum of other psychological symptoms that might manifest in your patient. So consequently, that has an effect also, because if you're to look at now what the consequences are, it's likely to result in increased morbidity and mortality in your setup, as you're discussing it. So significantly, you're going to get patients who are going to be staying in the hospital for long, prolonged periods of time. Plus, remember also, since the immunity is going to be affected, they are more prone to getting infections in the hospital setup. And at the end of it all, you get there's increased economic burden on the healthcare system. So you'll get malnutrition usually influences the disease outcome. As a result, you get if we don't think through it in terms of what is actually ailing the patient, what is the causative factor, you might end up having a prolonged period of time of length of stay in the hospital. You'll end up utilizing more resources at the end of it all, but it all boils down to what actually is making the patient to become malnourished in the hospital setup. So that now you don't simply think in terms of this could be starvation related, because more often than not, when it comes to the hospital or disease-related malnutrition, it's never about the starvation. It's more about the utilization of the nutrients. So additionally, there's also associated it's also associated with higher postoperative risks, especially for our surgical patients, with increased risks of contracting nosocomial infections, and also developing pressure ulcers being demonstrated among malnourished patients, because you'll find majority of the patients will end up developing pressure ulcers as a result, because they only want to be confined within the bed. They don't want to move around. So even affecting the blood flow, that's how the pressure ulcers come to be. So if you look at now in terms of the global burden, you usually get at times you find it's like there's a bias kind of, because if you look at that slide, it's mostly concentrating majorly on children, and that aspect mostly is about the community aspect. Okay, so if you look at that picture, whatever burden that is there, we are trying to bring up, it's only bringing out the community aspect picture. But I know wherever we are, even in whatever facilities you are, you might be encountering all these aspects of malnutrition, which are not necessarily starvation related, but disease related. So a greater proportion of the burden mostly is usually in the low and middle income countries. More so you get the elderly are usually the most affected. Reason being, they tend to suffer mostly from chronic diseases. They tend to have a low physical activity level. And then there's that aspect of social isolation and depression, because you see people move out, people want to venture out, people want to go and work elsewhere. So even as we are trying to think in terms of lack of employment in our country, you see, as you're looking for employment outside, it's likely to affect the nutrition status of the people you're leaving behind, of which those are your parents that you're going to leave behind, because who's going to be left taking care of them? Because you see, you're going to leave them in that isolation. They're going to become depressed because they have no one to talk to. Even when they're talking to you, it's more in terms of using the technology, talking to you via the mobile phone, which is a bit different from what they are socialized in terms of having a one-on-one. You being able to read the nonverbal communication from these elderly people. So you see, it also has an aspect in terms of how it is going to result in malnutrition in these elderly people. When you go to the Kenyan context, you can have a look at now. This is data from the KDHS. That is the Kenya Demographic Health Survey of 2022, the recent one. So if you look at now the trends, especially under the under fives, you can see the trend when it comes to the stunting, which is what is usually concentrated mostly when you're doing those surveys. You can see it's on the downward trajectory from that slide. When you talk in terms of underweight, it tends to go slower, of which it's more of a combination of the wasting and the stunted. The overweight, it's also showing it's going on the lower side. However, when you look at, you're trying to evaluate in terms of stunting, of which stunting is a marker of the deficient growth environment, having a deficient growth environment to which children have been exposed to, of which some of the causes which can be leading to stunting could be either recurrent infections or chronic diseases, many of which are complex and perhaps unknown. And then when you're talking now in terms of wasting, it's more of a measure of acute undernutrition, and it represents the failure to receive adequate nutrition, of which it may result from inadequate food intake or from a recent episode of illness or infection that causes weight loss signified by loss of muscle mass. Perhaps if you are to look at now the data, if you are to look at now the KDHS when it comes to the adult population, so you get like among women aged 20 to 49, it's saying 7% of them are considered thin, of which that is more of underweight, according to the BMI, while 45% are obese or overweight. So that is the KDHS 2022 data that is showing us in terms of among women of reproductive health, that is 20 to 49 years adults. 45% of those women are considered obese or overweight. If you look at the counterparts, that is the males, you get like, it's saying 14% are considered to be underweight. If you're to evaluate the BMI, vis-a-vis 19% who are being considered overweight and obese. So you can, if you look at that data, there's quite a big disparity between the aspect of the sex between women and men. Because if you're to look at women tend to be more obese, a larger chunk of the women are more obese than the counterparts when it comes to the male aspect. So if you have to look at that data in terms of comparison between the children and the adults, so you can see where the picture is in terms of the variability in that aspect. So our focus has been more towards the children and the community. But then what about the adults? You see, now it has to bring in that picture. Because you see, if you are having more population who are tending towards to be overweight and obese, then now the aspect of non-communicable diseases sets in, issues to do with the cardiovascular, issues to do with diabetes, renal, all those aspects now will set in, of which now the big question here is, now that we're in the clinical setup, what is the burden of the hospital-acquired malnutrition or disease-related malnutrition? Of which now here it is in terms of, out of the patients that are admitted in the hospital, how many usually come in well-nourished, but end up leaving being malnourished at the end of the day? And do we actually have that data? Okay, because you understand disease and inflammation can be a major contributor to nutritional decline, especially in hospital, due to its effects on the appetite, the satiety, the nutrient intake and absorption, and also aspect of metabolic changes, which usually result in tissue breakdown. So if perhaps I can just pose questions here, like how many hospitalized patients have you ever encountered in your practice that are at risk of malnutrition? Is it even considered a problem wherever you are? Would you say it is important for us to know the burden in our clinical setup? Because at least if you're able to report on that, if you're able to have that data, perhaps it might help us to formulate specific interventions which are targeted towards addressing that particular problem. But if we are not seeing it as a problem, and if you don't have data, so you get, we are likely to be not be knowing that there's a problem at the end of the day. It's you only who is only seeing the problem. The rest of the other people are not seeing the problem because you don't have the data. But if you now go into research, you'll find like the prevalence usually ranges from around 20 to 60%. of which it's a very, if you have to look at that, that is more like out of every 2 patients, 1 is likely to get malnourished while in the hospital setup, of which now that means we need to formulate interventions that are addressing that. And approximately a third of the patients who are not malnourished on admission may become malnourished while they are hospitalized. And the bigger gap now here is we don't have that data, especially in our Kenyan context, so that now you can be able to say, this is the way we need to move, this is the way we need to advocate for the resources when it comes to now the clinical management. Because I know right now there's that aspect of where we are talking about the SHA, the SHIF, all those key things, of which if you have to look at now what it covers, I don't know whether the nutritional aspect has been covered, of which it plays a greater key role when it comes to the outcomes, the clinical outcomes of your patient. Because the clinical outcome of a patient is not necessarily about issues to do with medication alone or the procedures. It also has to counter in terms of what's the nutrition status of your patient. Because remember, the key thing that is going to carry the medication or the medicines for them to work effectively is dependent on the status of the nutrition of your patient. Because something like albumin, it's a transport protein that is the majorly used to transport most of the medications to the systems. So if you are having a malnourished patient and you're busy looking at just simply the medication aspect of your patient, you see, you are likely to not succeed at the end of the day, because you also need to look at the wholesomeness in terms of how we manage the patient in the clinical setup. So if you go into now, what is the good clinical practice perhaps that we need to adopt? So we already know poor nutrition screening can be seen as a contributor to the occurrence of malnutrition within the hospital setup. So in short, what we are saying is we need to advocate for adoption of use of validated tools to screen our patients. So we need actually to actively look for patients who are at risk of developing malnutrition and prevent it from occurring for us to realize better clinical outcomes, of which loss of the body protein resulting from insufficient intake or increased requirements in disease is usually the hallmark of malnutrition in the hospital setup. So there's an associated lower prevalence of malnutrition and better nutritional care in hospitals when you're using validated tools, because it means you're actively looking for it. So if you're actively looking for it, then it means it becomes, you give it more attention to it. But if you're not looking for it, you're waiting for someone to tell you, oh, there is patient X and Y who need your intervention. You see, it would be already too late. But at the point of entry, if you are constantly looking for these patients, it becomes easy for us to get, how do we solve this problem? Because it also tells you what is the burden that you're dealing with, so that now, what measures should you institute to be able to prevent this? Now, when it comes now to the diagnosing bit, we need to support adequate intake, that goes without a doubt, and go far beyond just providing adequate amounts of energy and nutrients. So therefore, the identification and management of the multiple causes constitutes the basis of appropriate nutritional care in addressing this problem. Okay, so you can't just simply talk in terms of, oh, I've just evaluated the BMI of the patient. It becomes a basis of you diagnosing malnutrition. Because you understand at times the anthropometric or even the biochemical parameters can be confounded by several things. Because if you have to look at now the BMI itself, it does not actually reflect the acute changes in nutrition status, which is usually important in critical illness, of which the BMI lacks the sensitivity that other measures have, such as either you can decide to use body composition, and if at all you just simply utilize only the BMI, you'll end up with underdiagnosis of malnutrition in the patients, especially those ones with the higher BMIs, because there is aspect of sarcopenia in such kind of patients that need to be brought out. So even in terms of the advancements, in terms of how to diagnose it, we need to incorporate more in terms of diagnosis. We need to look into the aspects of body composition analysis of our patients, so that now we can be able to tell how do we timely address this issue before it becomes before it explodes and becomes a bigger issue that becomes it drains too much resources when it comes to managing it. So the best would be triangulating all the findings from all forms of their assessment. So you see, assessment becomes a very, very key component when you're dealing with the patient care. Because if you do a thorough assessment, you're likely to pick out those key things that are putting the patient at risk, and you're likely to address them. So, but if you do just a superficial assessment in your patients, you'll get like, you might not end up being able to elicit what is the causative aspect that is bringing about malnutrition in these particular patients. And it's going to make it a bit difficult for you when it comes to managing those patients. So as you know, determining an individual's precise nutrition requirements still remains a clinical challenge because of the most obvious reasons, okay? So most obvious reasons being different people come with different issues. There's a psychological aspect, there's a social aspect, there's the economic aspect that brings in that. Now, there's an aspect in terms of now the nutrient utilization itself in your patient. We need to actually be able to understand how is the nutrient utilization impaired in this kind of in the kind of patients that you're seeing. Because if you're able to understand that, then now you can be able to look now into the in-depth bit of how can we be able to clearly examine the patient and elicit, this is the problem, or this is what is causing this particular problem in this particular patient. So it is recommended that the most useful measure of nutritional status is a targeted history and examination. Okay, because a history will perhaps give you a picture in terms of how did it come to be. And when you examine the patient, it's going to give you a now, what they say, a picture is worth 1,000 words. So you see from that history, and when you examine your patient, then you're able to look at now what is the magnitude of the problem at hand, vis-a-vis how did it actually come to be. Because the history is going to be able to help you elicit that, pick that one out. If you come now to this now, how do we identify these patients who are at risk? Okay, so the figure you're seeing there is a summary of the diagnostic criteria or characteristics for identifying malnutrition in adults. Because you see, in pediatrics, it's almost straightforward, or it's a bit easier. But in adults, that's where now there's a bit of a challenge. And if you start with the first aspect, that is now the Academy of Nutrition and Dietetics and the American Society of Parental and Enteral Nutrition, you see, for them now the definition, it is more of a two-step approach. Whereby step one, they are defining malnutrition in the context of acute disease, chronic disease, or starvation. Remember the three things I told you in terms of, so it's either acute, is it chronic, or is it due to starvation? So after you define your patient or categorize your patient, then you move to the second step whereby now you're identifying malnutrition using two or more of the following characteristics. So for the Americans, they're either using insufficient intake, history of weight loss. They're looking now in terms of loss of muscle mass, loss of subcutaneous fat. There's also aspect of localized or generalized fluid accumulation with a diminished functional status. If you go to their counterparts in the European PET, Society of Parental and Nutrition, it's also a two-process PET whereby they're identifying malnutrition risk using validated tools like the malnutrition screening tool or the malnutrition universal screening tool. And then at the second step, now they go further to look at now they're diagnosing malnutrition as either a BMI of less than 18.5 kilograms or an intentional weight loss, which is usually a mandatory thing for them to do, plus at least one additional criteria of either low BMI or low fat-free mass index. Now, there's this other aspect that was brought about by several, to be specific, for clinical nutrition societies. That is the ESPEN, ASPEN, FELANPEN, and PENSA, which came about with the GLEAM criteria. That is the Global Leadership Initiative of Malnutrition criteria, which was started in 2016 from these 4 societies. And it's more of a common global framework. It's more or less a consensus. It is consensus based and contains a minimal set of indicators typically used in the clinical practice to standardize how adult malnutrition is characterized in any clinical setting. So when you're looking into that, so you get like it is used concurrently with validated nutritional assessment tools. Either you can decide to use, if you're using SGA, that is subjective global assessment, it can use concurrently together with this. So the first step is you screen to identify at-risk status using any validated tools. It can be the MAST, it can be the SGA, whichever you in your hospital setup you are preferring to utilize. And then on the second step now, it is whereby you assess to diagnose and grade the severity of that malnutrition using at least one phenotypic and one etiological criteria, of which when you're talking now in terms of phenotypic, we're talking about non-volitional weight loss, we're talking about low BMI and reduced muscle mass. So when you're talking about non-volitional weight loss, they're defining it. So for you to be able to say the threshold for diagnosis of malnutrition, it requires at least one phenotypic criterion and one etiological criterion for you to diagnose the malnutrition. So at least it's trying to marry two criteria for you to get a definition of, for you to at least be able to clinically diagnose malnutrition in your patient. So when you're talking about non-volitional weight loss, they're referring to it as a weight loss more than 5% within the past 6 months, or a 10% beyond 6 months. Okay. When you're talking now in terms of the low BMI, they're saying for geriatric population, it is you're looking now in terms of a low BMI for patients who are above 70 years or less than 70 years, that is below 18.5 for those ones who are below or even above. And when it comes now to reduced muscle mass, you see now that's where we have a bit of a challenge, especially in our clinical setup, because it has to be by validated body composition measures or techniques, of which it calls for us to be able to have body composition analyzers or bioimpedance equipment for us to be able to analyze the muscle mass of our patients to be able to get a report at the end of the day. When it comes now to the etiological criteria, whereby it is evaluating aspects to do with the reduced food intake or assimilation. So there they are talking about if the patient is not able to meet 50% of his energy requirements for more than a week, then now we see that becomes a criterion for you to be able to say this patient is at risk of malnutrition or is going to be malnourished or is having GI symptoms or chronic GI conditions that are adversely impacting food intake or absorption or perhaps assimilation of those particular nutrients in your patient. The second aspect in terms when it comes to the etiology is about the inflammation bit, of which in acute disease or injury or even chronic disease related, they'll evaluate now the C-reactive protein, that's the CRP, which may be used as a supportive measure in diagnosing malnutrition for those patients. So in conclusion, there's that review that was done by Corella and his colleagues, whereby the GLIM criteria has been used or has been studied extensively since its publication. And you find like low BMI was the phenotypic criterion used mostly or more often, whereas both food intake and assimilation and inflammation or disease burden were frequently employed as the etiologic criteria. So perhaps you can also try to borrow from there and see if perhaps if we are to run that within our clinical setup, are we able to sort of like generate data in terms of how many patients are we perhaps seeing who are malnourished? If you're to perhaps try to adopt or try to utilize the GLIM criteria and see if is it going to work for us, especially now that we are in a resource limited setting. kind of area. So when it comes now to the nutrition prescription, that's where it's more of a game changer, because it all depends with now how are you viewing it. So rather than thinking programmatic in terms of you thinking in terms of F75, F100, now you have to get a new picture of when it comes to disease-related malnutrition, perhaps F75, F100 might not be able to address those key issues that you need. Because if you're to look at now how much you're targeting in terms of the energy and protein aspects. So when you're thinking in terms of the energy, so you have to think, if I can use this analogy, think of it in terms of petrol that is needed in an engine. And then the patient now here himself now is the engine size. Think of it in terms of the engine size of a vehicle. So there are those patients who are more of guzzlers, there are those patients who are perhaps going to consume less of the energy. So therefore, the amount of petrol you need to cover the same distance will differ greatly depending with the engine size that you're having, okay? Plus, you see the amount of energy you're going to utilize. It also depends at what phase, because there are other factors that are going to play in the background. Either you're going uphill, either you're going downhill, either you're carrying more load, either you're off-road, or either you're on a highway. So the amount of energy you're going to need there is going to be different. So at always, whatever you're trying to look at is you're always trying to aim for the bullseye as you're managing your patient. So these things are likely to be shifting every other time. So you need to be cognizant of that, such that today I planned this, tomorrow things might have shifted. So I also need to shift as the changes are occurring, because nothing is constant there. So there's a continual shift in terms of your targets. So you need also to be looking at those shifts, because you have to keep in mind in terms of there's no silver bullet for treating malnutrition. It is not like the programmatic way where it is cause of starvation. No, when it comes to now disease-related malnutrition, there's no silver bullet for treating it. So you have to be able to focus on the identification of the potential underlying causes of that malnutrition, as well as what that individual preferences are. What resources do you have? What are the expectations at the end of the day? You have to look at now, evaluate the severity of the deficit itself that you are dealing with. You also have to critically review the dietary prescriptions that are being made, so that now you're able to come out of the woods, if I told you to come out of those woods. But simply just going into the saying this is how you usually go about it, you might end up losing it at the end of the day. Because the choice of nutrition therapy, you'll find it's dependent on various other factors. Because the patient disease state, you're trying to look at now the metabolic response to stress in this particular individual. Is the GI tract accessible or not accessible? Is it compromised in any way? Did they do any resection in this particular patient, perhaps? So if they did resection, which bit of the resection was done? Was it the jejunum? Was it the duodenum? Did they actually bypass the stomach? You see, all those things have to come into play, because they're going to affect even in terms of what choice of therapy would you want to ever give to your patient. Would you perhaps want to look at disease-specific kind of formulations, whereby you're thinking of elemental or semi-elemental feeds for this particular individual? What are the nutritional goals? Does the patient require, do they suffer from any allergens that are perhaps exacerbating the symptomatology in your patient? So what are the long-term requirements for this particular patient? So that now you can be able to evaluate the feasibility of introducing enteral nutrition, either on the short term or on the long term. Or perhaps would the patient require parenteral nutrition for you to be able to solve the problem, okay? So what is the current nutritional status of this particular individual? You see, in severe malnutrition, the gut function is usually compromised due to the gut wall becoming either edematous and then now the villi becoming atrophied. So you have to look into all those other contexts when it comes to the choice of your nutritional therapy. Because remember, when you're talking about therapy, it's targeted. It is not prophylactic. It is more targeted. This is what you want at the end of the day. This is what you want to correct. Are you succeeding in that, in correcting that? Because when it comes now even to the choice of whatever you're utilizing, you have to look into now the characteristics of those particular feeds. Are they elemental, semi-elemental? Will the patient be able to absorb those nutrients that you're targeting, or perhaps you do need to give them parenterally for them to be able to benefit. Even in terms when it comes even to macronutrient distribution ratios, it's not just simply macronutrient distribution ratios. You have to go even into the specifics, because even how they're metabolized is very different. Because an instance, let's say, for example, if you're utilizing long chain fatty acids vis-a-vis medium chain fatty acids, how they're metabolized is very different. And the kind of waste they're going to create is very different. Will the patient be able to get rid of all those things? Because yes, you're simply talking about fat, but which type of fat would be suitable for that particular individual? Is it the long chain? Is it a medium chain? Okay, so we have to evaluate those to the core whenever you're dealing with disease-related malnutrition, because at the expense of it, just looking at it as fat, at that face value, it might not help solve the problem. So the key aspect is looking at the core bit. And that's where now the greater load comes in whenever you're coming now when you're working in the clinical setup. You might not work as someone who is working in another program. Let's say, for example, you might not work how someone else would work in an outpatient program or a community program. But now you have to be able to think more than what they're having out there. So you have to think out, how am I able to help or assist this individual tweak his usual foods to be able to solve the problem at the end of the day. Because remember, you don't want more readmissions again back to you. So you have to think deeper than the current scenario that you're having in your patient. So you have to look at now the accessibility of those particular foods. So you have to actually conduct very thorough nutritional counseling or interventions that are going to help that particular individual. So that now they understand, why are you telling them to do things in this manner, as opposed to what they're usually hearing from other people. You see, we are social beings. So there's what someone was told, they share that with someone else, they go try out that one, it doesn't work, then they're like, you guys are usually liars. You see, at the end of the day, the information that is tailored has to be conveyed to the patient to understand, this is what you yourself, particularly you, not us, you, that you need at the end of the day for you to be able to see good clinical outcomes. So in conclusion, what am I actually simply relying? I'm relaying in terms of, we need to proactively screen for malnutrition, because it's very, very paramount for us to know what is the burden that we are shouldering in our facilities, or what is the burden that we are encountering, so that now we are able to even advise the government in terms of which is the direction to take when it comes to the clinical aspect and management of disease-related malnutrition, so that you can actually be able to tell them things like F100, F75, they're equally good, but in the clinical setup, it might not be able to help solve the problem of your patient if they strictly want to help these patients to benefit from whatever they have. And all patients are usually unique. So someone who's presenting with alcoholic steatosis is very different from someone else who's presenting with other issues. You know? So whenever you're having such kind of malnutrition, even how you treat that will not be the same way how you be able to treat another person who has features of malnutrition. So it's very, very paramount for us to think of them as unique creatures. So the assessment there becomes very, very crucial. And for that matter, thorough assessment, not just superficial assessment whereby you're just simply assessing the weight and the height and calculating the BMI. No, you have to go further than that. You have to be able to do body composition analysis. So that now it helps for you to be able to know, how often would I be changing my interventions in this kind of patients. And most importantly, there's no standard diet prescription when it comes to disease-related malnutrition. So you cannot say this is the cure for this, no. So no standard diet prescription, so it calls for individualization. So we are being encouraged to enhance and utilize evidence-based practices, of which they are available. It's only for us to be able to push for them to occur. And with that, the only conclusion here is there's no silver bullet or instant cure for malnutrition. So as long as we know that, then I'll be able to think outside the box. It is not going to be life as usual. So thank you very much.
Thank you very much, Mr. Agri, for that wonderful presentation. And actually, it has reminded me of a seminary paper done by Dr. Whitworth Jr. in early 1974. The paper was about skeleton in the hospital closet. I'm sure most of us are aware of this. And actually, in that paper, if I can quote, there's something interesting there I observed that states that there was awareness during this time concerning hospital malnutrition. And if I can read the quote there, says that as awareness of the role of nutrition in recovery from disease increases, physicians are becoming alarmed by the frequency with which patients in our hospitals are being malnourished and even starved. One authority regards physician-induced malnutrition as one of the most serious nutritional problems of our time. And at this current time, I wonder, will authorities regard nutritionist-induced malnutrition, or what do we say? So in the spirit of Malnutrition Awareness Week, we have a great role. And for nutrition care process, for all of us who understand this, the first support system is screening. But screening is not enough. We need to have interventions that are working. We need to have an enabling environment. It's all about multidisciplinary approach in management of disease-related malnutrition. And I'm very excited, Mr. Agri, for this presentation. And I hope even our audience have enjoyed the discussion. I'm trying to check if there is some questions that we can attend to. Yeah, I haven't seen any question. If you have a question, perhaps one or two we can be able to address within the remaining few minutes. Okay, there is a comment there. Anonymous attendee. I think this one is addressed to the right person concerning the CPD tokens. So perhaps what I would be interested to know is that if there is any health facility that has made use of GLIM criteria or developed a screening tool that for screening for malnutrition, I would be interested to hear feedback if there is any that has developed this. And also perhaps if in our health facilities, do we have screening tool for malnutrition? Who screen, who do the screening? Is it nutritionists or within the multidisciplinary care team who are assigned with this role of doing nutrition screening? Okay, there is one question. Can you use BMI in screening pregnant mothers? This is from Jonah Mengich. Can you use BMI in screening pregnant mothers? A very good question. Because for nutrition screening, you have to use you really have to, in nutrition care process, we talk of critical speaking skills. You use the right tool for the right purpose. I don't know, Agri, would you feel like you want to attend this?
So when you're talking about pregnant mothers, you see, even the choice of what you're using has to come in terms of its context. What does it evaluate? Because if you look at BMI, so BMI it's an index of trying to look at being computed using your weight and your height. And then when it comes now to the pregnant mother, you see there's a very big difference there. Because a pregnant mother, there is the aspect of the fetus. You know, it's not one individual you're dealing with. So there are two. So you're expecting them to gain weight. So at the end of the day, even the BMI that you're computing, I highly doubt you even be able to interpret what it is. Because at the end of the day, there is no such you can't be able to utilize whatever you calculated there. Yes, you're going to have the weight of the patient that is given. You'll be able to even to get a very perfect height for that particular mother, be able to compute a very nice BMI. But then now the other aspect now is how do you interpret it? Because you see, you're not doing it for the sake of doing it. You're doing it because you want to utilize that information to inform you of what next. So if I told you to use a BMI in screening pregnant mothers, I would assure you there's nothing much you're going to get out of that because it's not going to tell you anything. So it simply tells you even when you're screening pregnant mothers, BMI is not going to feature. And that's why I was presenting mostly on, if you look at now the Glean criteria, it's not necessarily looking at just BMI purely. There's that phenotypic aspect in terms of you're trying to evaluate muscle loss, you're trying to evaluate non-volitional weight loss, and then there's aspect of weight loss. So for you to be able to diagnose, so at least you need to have one of those there. So it doesn't necessarily mean you have to compute BMI for every other patient, no. So you choose the screening based on the patient. Would it give you data that can be able to interpret for you to intervene? If it's not going to give you data for you that is useful, there's no point of you going ahead to do it because it has to inform you. So whatever information you're getting has to inform you of what is the next step to do or what's the next step to take. Thank you.
Thank you very much for that wonderful response. There is another question from Mohammed Adan, and he is asking, if I may ask, is there any standardized dosing for parenteral nutrition? Standardized dosing for parenteral nutrition. Well, these are good questions. And from there is that slide Mr. Agri has shared on special consideration when it comes to choice of nutrition therapy. There are a number of factors you need to consider. And based on this, I don't think you'd have a standardized dosing for parenteral nutrition. And actually the term parenteral nutrition is a little bit broad, because sometimes you may use supplemental parenteral nutrition when you are doing some orals, and there is a time you can do total parenteral, and also at certain times you may be interested in doing peripheral parenteral nutrition. So I would appreciate if you can be a little bit specific so that we see if you can be able to be of use.
Well, perhaps an additional comment on that in terms of standardized dosing for parenteral nutrition. Well, if I was to try to simplify it this way, when you're talking about nutrition, you're actually focusing on nutrients purely. There's nothing else. Focusing on nutrients. Whether they are macronutrients, micronutrients, you're just simply focusing on the nutrients. Now, when you're talking about parenteral, it's just a mode of availing those nutrients to your patient. So the key aspect here is, if at all you want to meet someone's nutrient requirements, how do you do it? Because you see, nutrient requirements for me would be very different from what Mahamud, his nutrients requirements would be. So what I just simply need to do is I just simply need to meet your nutrient requirements. Because if you talk about now standardized dosing, when you talk about standardized dosing, then it simply means it's something whereby you can't go off it. Because now here you have to understand when you bring in the aspect of disease-related malnutrition, because remember there's what I was telling you about now, the causes. There's a time whereby the losses are way more than the uptake. There are times whereby the requirements are higher than usual. So you can't use a standardized dosing way for such kind of patients when you're dealing with the disease-related malnutrition. Because you see, for you to correct it, you need now to individualize that dose for that patient. Because remember, it is not a drug. Now that's the other key bit we need to understand. It is not really a drug, in quotes. That's what I can say, if I can be able to say it that way. it is something that you want to utilize therapeutically to be able to meet the needs of the patient such that he's able to maintain his normal body function. So remember, these are nutrients. They are not just simple components that you're looking at. Because you see, if you equate it to a drug, it's more of like something you have extracted that you want to utilize. But here, you're utilizing food to be able to manage the patient to prevent malnutrition. So I wouldn't want to narrow it down to a standardized dosing for an individual, because it has to be individualized from one individual to another.
Okay, thank you very much for that quick response. There is a comment here from Wilson Gashari, and the comment is that for disease-related malnutrition, we tend to focus more on looking for it among patients with wasting diseases such as TB, etc. Thank you very much for highlighting this, because we certainly need to make it a norm to nutritionally assess patients. I agree. Screening is the first part, actually the entry point for nutrition care process. So that when you identify at-risk patients or patients who are really undernourished or overnourished, appropriate intervention is instituted. There is an anonymous attendee making also a comment that for nutrition screening, a nutrition profession is the one supposed to do that. That is why for any clinical setup, the professional guidelines recommend a nutrition or dietetic professional at the screening center. Thank you very much for that. Okay, so there's another issue that screening tools are there. Anonymous attendee saying that, and on screening tools, there are serious problem because of lack of clear nutrition funding, which affect availability of tools of service for the profession. The tools are available, availability is the problem. Well, on this, when it comes to screening, there are other ways, as Mr. Agri had mentioned. Actually, we have what we call subjective global assessment tool. It's a simple tool that you use subjective measure to diagnose malnutrition, and you can be able to label a patient whether is severely, mild, or moderate, or normal nutrition status using very simple tools. Even you don't need weighing scale at the screening point. It's just few, you ask few questions, you make observations, and then you are able to determine the patient, where the patient lies in terms of nutrition status. But they are very disease specific. For example, you have subjective global assessment tool, dialysis malnutrition score for hemodialysis patient. We have for pediatrics. We have even for patients with cancer. So they are very specific, and probably they should be, we should have screening tools depending on where it is used, that is tailored to meet the needs. All right.
Perhaps if I can add to that, there's a difference between screening and assessment, of which from the anonymous attendee, I think it was an anonymous attendee. Screening, I believe, this is now my opinion, screening can be done by anyone, so that you can be able to see the picture. Because if you have to look at now the setup, how many of the nutrition professions or the dietitians are in service? Because at the end of the day, we are trying to solve a problem, not create a problem. So in solving, screening perhaps would be, it's the entry bit of it, and it's supposed to be as simple as possible, such that anyone can be able to do. But then when it comes now to the assessment, no one else can be able to do nutrition screening, no nutrition assessment better than the professional himself, that is the nutritionist or the dietitian. So that now when it comes now to the assessment, that's where now it is more thorough and more in-depth in comparison to screening. Screening is more of a superficial way, but then when it comes now to assessment, it's more of an in-depth way of evaluating the patient. Screening is just telling you, it's more like raising a red flag somewhere. telling you there's a problem here. We need to find out where is the problem arising from. Now, assessment now tells you where is the problem arising from, but screening cannot tell you where the problem is arising from.
Thank you very much. There is someone else called a couple. And there is a comment and also a question here. Aiming to capture nutrition data from hospitalized people, it will be necessary to impose a daily assessment of the nutrition status of patients in our hospitals. Is this possible? I agree, this is possible, this is possible. It has reminded me of, if you have managed to have a look at a document by Minister of Health, Nutrition and Dietetics Unit, Kenya National Action Plan. I remember for those who participated in developing this, there was a strong push to be able to feature clinical nutrition at the top, which has not been there before, because other sectors were reporting they had data. We have micronutrient initiative, we had what we call emergency nutrition, we have MOICN and others, but clinical nutrition in respect to curative services, it was really not reflected there. And in that document, they had put we call it a performance indicator in terms of screening of nutrition status screening as a baseline to start with. And I don't know how far it has gone, but what I know is that this, if we can be able to have this and then we have data consolidated, it can really speak out, and it should be a very good starting point where we can be able to move forward in terms of improving the care of inpatients. If screening is not well done, the assessment and diagnosis will not be correct. That's another anonymous attendee. Thank you very much. There is another person, the last one. What are the nutritional advice for people with HIV and AIDS? What are the nutritional advice for people with HIV and AIDS? Well, this is a good question, but today we were discussing about disease-related malnutrition, but perhaps you may need to check national guideline for HIV, which here is the latest update, because even with HIV AIDS, nutrition management, it's purely dependent on the factors that we have highlighted here, as Mr. Agri had mentioned. So it will really depend on unique needs of the patient and many other factors. Yes, or Agri, you need to have some additional, please.
Well, just to add into the additional, I think you've already actually answered it very well. You see, when you look at nutritional advice for patients with HIV and AIDS, you see, you can even have a patient who is HIV positive who needs parenteral nutrition, or they have HIV with other issues who need surgical intervention. The HIV patient who has another medical cardiac problem. So now you see how the nutritional advice is going to be tailored for those patients would be very, very different. So the end in mind here is not to categorize patients based on the diagnosis itself or the medical diagnosis as HIV/AIDS. The key here is what are the requirements or what is the wholesomeness of that particular patient having, or that is going to predispose him to getting malnutrition. Because you get a HIV patient who needs surgical intervention. So the advice that you're going to tailor for that particular individual would depend and would be very different from a stable HIV patient who does not require any surgical intervention. So you cannot actually be able to give a standard prescription for the two. That's why I was saying there's no standard diet prescription, which needs to come out very, very clearly in this presentation in terms of there's no standard diet prescription. So you don't categorize your patient based on the medical diagnosis. Remember, it's an individual. You're dealing with a human being. You're not dealing with a disease. You're dealing with an individual. So you actually need to manage the individual, not just the disease itself. So you cannot Managing the disease, it's removing the disease, managing it, and then returning it to the patient, which is not what you're cut out for. You're cut out for managing the individual with the disease, so that they're able to live, they're able to have a normal life out there. Because if you try to manage the disease and then now the individual, there'll be a very big problem, and your intervention is not likely to work, and they'll keep running away from the health facility simply because they're not seeing results. They're not seeing why should they actually come in and pay for the services if at all nothing is getting out of, they're not getting anything out of it. So thank you.
Thank you very much for that input. I don't see any other comment or question from audience. I think we are doing well. So, Agri, what is the parting shots?
Well, my parting shot, it was very simple. It was like the last slide where I was telling you there's no silver bullet. So don't expect a silver bullet that is going to cure malnutrition, especially in the disease, especially in disease-related malnutrition, because it is unique in each and every patient. So the only key bit here is you need to individualize that care, no standard diet prescription, and we need to be proactive. So I think perhaps right now is when we need to come out and agitate for us to be able to, for nutrition bit to be included in this particular SHA or SHIFT thing that is being the topic of the day, because you see, it has a very big impact in terms of the outcomes of our patients. Because at the end of the day, if I'm having a critically ill patient and I cannot be able to prescribe something for the patient for him to get better, the medication he's getting is equally going to be, for lack of a better word, useless. Because you're going to be spending more, but you already know the outcome. Why don't we think of the patient wholesomely in terms of all centers being inclusive, rather than just simply looking at, we just need to cover the diagnostic bit and we just need to cover the medication bit. If you just do that, it will be as simple as the comments I had already said. You're just managing the disease, you're not managing the patient. And we need to move away from managing the condition and manage the individual with the condition, because you need to be able to give him a better outcome, because that is what we are envisioning. We want better clinical outcomes, of which for better clinical outcome, we have to work as a team from every center, from the person who cleans to the person who prepares the food, to the nurse, to the doctor, to the nutrition, to the physiotherapist. All of us need to work as a team. So there's no one who's going to be like the god of the other. If someone starts seeing themselves as the god of the other, then that's when we begin to fall, all of us. So thank you.
Thank you very much. There is no silver bullet to address disease-related malnutrition. Actually, called disease-related malnutrition in using another word as secondary acute malnutrition, and it's quite different from what we know and what integrated management of acute malnutrition guidelines stipulate and dictate, and even when it comes to managing of children. And that's why it becomes very complicated, because the dosage that are given to manage such children in clinical setting, it's quite different, and most often it fails. Thank you very much for showing up. Until next time for our nutrition series, I wish you well.